All right. It is noon and I do see people jumping on still. Welcome everyone to our educational webinar titled Bump Up Your Immunity on Pregnancy and Vaccines. I think I'm going to get us going here. My name is Mary Lizakowski, and I'm a Coalition Health Director with Foundation for a Healthy North Dakota. It is a nonprofit established in 2022, and we are comprised of a small team. Our mission is to promote health and wellness by working at the community level across North Dakota. We are building a statewide coalition to allow local communities to collaborate and work together on common initiatives. And by joining the coalition, members will be the first to know about educational opportunities such as this, the latest on relevant public health information, legislative updates, and access to digital advocacy resources and toolkits. Just some housekeeping things to touch on. Webinar attendees will be automatically muted for the presentation. If you have questions, please put them in the Q&A box. Our team will be monitoring the questions that come in. We will be recording this presentation and we'll leave time to address any questions you may have along the way or at ones that came in at registration. And after the presentation, a link to the recording will be sent out and will be on our website along with an evaluation survey to complete. It is my pleasure to introduce our speakers today. First is Melissa Pytlik Monson. She is a physician assistant at Sanford Health who specializes in women's health services, specifically obstetrics and gynecology. She received her education and training from Marietta College in Ohio. She believes in providing inclusive care and building relationships. She strives to treat each person as a whole and is passionate about education and helping them understand their bodies. She believes that good healthcare comes from the teamwork between the provider and patient. And next we have Dr. Andrew Williams. He is an assistant professor in the Department of Population Health at the University of North Dakota School of Medicine and Health Sciences. Dr. Williams is a perinatal epidemiologist with an interest in structural inequalities in obstetric and pediatric health outcomes with consequences across the lifespan. He completed a postdoctoral fellowship in the epidemiology branch of the Eunice Kennedy Shriver National Institute of Child Health and Human Development. He completed his PhD in maternal and child health from the School of Public Health at the University of Maryland in 2017. Currently, he is leading the Stress and Health in American Indian Pregnancy study, investigating associations between adverse childhood experiences, historic trauma, stress, and infant growth among American Indian women in North Dakota. As Executive Director of the North and South Dakota Perinatal Quality Collaborative, Dr. Williams has secured funds from the Centers for Disease Control and Prevention and the Health Resources and Services Administration to implement quality improvement projects at prenatal care sites in the region. So thank you both for being here today. And I'm going to turn it over to Dr. Williams to start us off.
Great. Thank you, Mary. Thanks for having me. What I'm going to do is just take a quick look at some of the data regarding flu vaccine during pregnancy. And we'll take a look at some of the national level data from the CDC, and then also some North Dakota specific data as well, just so we can get a context of kind of where we're at with flu vaccines. The CDC does regular surveillance of flu vaccine coverage among pregnant people in the United States, and they get this data from a variety of sources, including surveys and electronic medical records, and they do fairly regular reports during the flu season. So this is the most recent figure that they have up in terms of looking at trends over the last few years. And what we've seen in the United States is that only 49% of pregnant people in the US had a flu shot either during pregnancy or before pregnancy in the last flu season, so the 22 to 23 flu season. And this is somewhat concerning because we know that there has been a trend over the last 4 to 5 years of declining flu vaccinations among pregnant people in the US. And this is just the overall data. We'll take a look at some kind of key demographics, especially ones that might relate to North Dakota specifically. But just with this figure is we see that the pink line on the very top here is the 2019 to 2020 flu season. The blue line is the 20 to 21 flu season. The orange line is the 21 to 22 flu season. And this purple line at the bottom, that's just under 50%, is the 22 to 23 flu season. So we've seen just in the last couple of years, about a 15% drop in pregnant people who are protected with a flu vaccine. Now, here's just some data looking at the overall rate of flu vaccine during pregnancy, and then looking at some age and race distributions here. So the overall rate is currently at about 48% based on last year's data. And then on the age chart, we do see that the younger population has lower rates. So the pregnant people between the ages of 18 to 34, it's about 47%, whereas the older population, so the people between 35 and 49, it's about 5 to 6% higher there. And then we do see that there is some variation by race ethnicity as well. So between, and this is CDC data, so these are the only categories, racial ethnic categories that they report on. But we do see that the white population, the Black population in the United States are both right around 45%, whereas the Hispanic population is the highest, according to recent data, at just over 56%. And then this amalgamation of other race ethnicity people is just over 52%. So even though we do see some variation here, we're not necessarily seeing that one group is substantially higher than the other. Everyone's around that 50%, just below, just above that rate. Then I also wanted to present the data on rurality and also poverty, as these are typically really good indicators of access to healthcare, and especially important in a state like North Dakota, where we have such a big rural population. And nationally, we do see that there is a pretty big difference between the urban population and the rural population. As we see, the rural population is just at about 39% of pregnancies receive the flu vaccine, and then just about half the urban pregnancies receive the flu vaccine. And then the split is actually pretty similar for individuals based on the poverty level as well as the national level, where it's just over half of the individuals that are at or above the poverty level. So there's those higher income families receive that flu vaccine during pregnancy. And then the families that are below the poverty level, it's about 38 to 39%. So a little bit bigger difference here than by looking at some of those other key demographic categories as well. So I want to bring it home, look just specifically at North Dakota data. All of this data is from the North Dakota Pregnancy Risk Assessment Monitoring Survey or system. And this is the annual survey that the State Department of Health does. And they survey a sample of pregnant women a couple months after they've given birth. So on the left-hand side, we have the overall population. And for this data, it's broken down a little bit differently than what the CDC provided. But we get the estimate of about 11% of pregnancies in the state are vaccinated before pregnancy, and then about 59 to 60% during pregnancy, and then about 30% do not receive the vaccine whatsoever. Among the white population in North Dakota, very similar to the overall, in which it's about 10% before pregnancy, about 60% during pregnancy, and then about 29% not at all. And then we do have some differences when we look at some of the other racial categories in the state. For the American Indian population, have a little bit higher rate of flu vaccines before pregnancy, so they're at 13 to 14%. But then we have a little bit lower rate during pregnancy, where it's only just over half. And then over a third of the American Indian pregnancies do not receive the vaccine at all. Then for the other racial categories as well, we do see a higher uptake in the before pregnancy period. So this mirrors pretty similarly with some of the national data that Hispanic and other racial people were getting vaccines at a higher rate than other groups. And then we do see it's about 55% of other racial identity people receive the vaccine during pregnancy, and then about 28% don't receive the vaccine at all. So across the board, we are seeing that the don't receive the vaccine during pregnancy is fairly similar. It's about a third, a little bit under a third of the population, whether you look at it overall or by the main race ethnicity categories that we have in the PRAMS data. And this is looking at the same indicators by income. And what we're seeing is that when we're looking at the low income individuals, we're seeing that they actually have the higher rate of getting their vaccine before pregnancy. So the gray is individuals that are making less than $40,000 a year, whereas overall and above $40,000 a year is about 11%. So they're about 2.5% higher there. But then if we look at during pregnancy, the individuals that are receiving the flu vaccine more often are the individuals of higher income, where they're at about 63%, and about 12% higher than the low income individuals. But we are seeing that there's still a good number of people getting, over half the people that are receiving the flu vaccine are getting it during pregnancy, kind of regardless of income and at the overall level. And then we do see some differences when we're looking at the did not receive the flu vaccine during pregnancy in North Dakota. Overall, we're at about that 30% level, whereas the higher income individuals are about 25%, but then the low income individuals are at about 35%. So that's a 10% difference there. So that might be one area of concern to be thinking about moving forward. Then also want to look at it by age. We see less drastic differences by age in North Dakota than we do compared to the national data, because we see that this orange category is getting the vaccine during pregnancy, and we see that it's high 50 to close to 60%, kind of regardless of age. So there really isn't a big difference here. Where there might be some differences is in the before pregnancy category. We get 14% of the women that are over the age of 35 are receiving the vaccine before pregnancy, and then about 10 to 11% of the younger women are receiving the vaccine before pregnancy. And then that's kind of reflected to the no vaccine as well. So we have a smaller percentage of older women not receiving the vaccine, and then about 30% to a third of younger women not receiving the vaccine either. So some slight differences there by age. There we do see some more substantial differences as we're looking at the urban-rural status. So in North Dakota, we look at the counties and how the counties are indicated for urban-rural status. And looking at the urban population, we see that about 13% of the women are getting vaccinated before pregnancy, 63% of the women are getting vaccinated during pregnancy, and only about 24% of women don't receive that vaccine. Whereas in the rural population, only about 9% are receiving that vaccine before pregnancy, about 55% receive it during pregnancy, and then 35 to 36% are not receiving that vaccine at all. So looking at the urban-rural differences, both in all three of these categories are potentially very meaningful, which it's about a 12 to 13% difference in the not receiving the vaccine at all, and about a 10%, 9% difference in receiving it during pregnancy, and then about a 4% difference receiving it before pregnancy as well. So definitely some differences there based on where people are residing and perhaps also where they're getting their care. Now, I also wanted to present just a little bit of trend data since the CDC presented that nice map of trend data over the last few years as well. And so this is plotting out from 2017 to 2021, the percentage of people overall that are reporting getting the vaccine before pregnancy, during pregnancy, and not at all. So the blue line on the bottom is getting the vaccine during pregnancy. And there really doesn't seem to be much of blue line is getting the vaccine before pregnancy. And there really doesn't seem to be much of a difference between the 5 years. 2017 was 9%. It peaked at 13% 2019, but really it's a percentage point here there where the changes are really happening. So it doesn't seem to be much going on. Overall, people are getting the vaccine before pregnancy. 11, 12, 13% is probably where we would say that happens. And that's what the overall looks like as well. Where we do have some differences or some change is when we look at the no vaccines and then getting the vaccine during pregnancy, obviously. And so just to highlight the areas that seem to be concerning is in 2021, only 54% of pregnant women said they reported getting the vaccine during pregnancy, whereas 34% said that they did not receive the vaccine at all. And this is concerning because that's a pretty big jump towards the bad side, towards the not being protected side, even just from the year before. And it seems to be pretty different from the trend that we would see in the preceding years. With the not getting vaccinated at all, we see that it's about 30 to the mid 20 percentages, and then it jumps up almost 10% between 2020 and 2021. And then for the getting covered with the vaccine, it's about 60% for the preceding 4 years, but then we only see about 54%. Albeit we only have 1 year of data that's showing this dip, so maybe this is just going to be an anomaly, but it's something to keep our eye on. And then I also wanted to just look at the data about whether or not people are talking to their healthcare workers about getting a flu vaccine during pregnancy. And again, potentially concerning outcomes in the last 2 years, but again, we'll kind of have to see what more data says about this. The blue line on top is, yes, I talked with a healthcare worker about getting my vaccine, and we see that the average over the last 5 years is just over 90%, but looking at the 2017 to 2019 data, it's about 92%, whereas the last 2 years, it's starting to show that maybe it's dropping off just a little bit, albeit it might only be a couple percentage points. And so again, we may have to wait for more data to come out to really get an understanding. And obviously reflecting that, we do see that a little bit of increase in women reporting that they did not talk with their healthcare provider about getting a flu vaccine. And so while these might only be slight changes in the data, if this continues to hold, obviously we could see more drastic changes in the future. And this is really important because we know that simply just having a conversation with a healthcare worker can really increase someone's uptake of a behavior change or accepting something like a flu vaccine. So if we can make sure that healthcare workers are discussing this with their patients, and as many patients as possible, we'll be able to keep our flu vaccine rates up. So thank you very much. Just wanted to present those few slides. And next, I'll turn it over to Melissa. Thank you.
Awesome. Thank you for that. Hi, all. My name is Melissa. I am a physician assistant. I practice in OBGYN. I will do my best to get my screen shared here. So talking about maternal vaccination and pregnancy. So this is a conversation that I really enjoy having. I think it's a big part of my job and something I'm really passionate about. So why me? So I was approached by one of the physician colleagues that I have about working with this foundation and the important work that they do. So I've been in practice in North Dakota throughout my career, and I have had the opportunity to talk with many patients about many different vaccines over the course of my career. And one area that I feel really passionate about is talking about the impact of vaccination in pregnancy. And so this was a really, really cool opportunity for me. So I appreciate you all being here. So objectives today, I would like everybody to understand what vaccines are we talking about? What are we talking about that's important in pregnancy? Why are we talking about these vaccines? What are the hesitations that people have? And where can you go to get reliable information, either for yourself or for patients or clients that you might be working with? So when we talk about vaccines, I think about back to when I started, and the order that I listed these vaccinations in is actually kind of the order in which they appeared in my conversations with patients. When I first started practice, I often opened the conversations as there are two vaccines that we recommend in pregnancy, and those are the seasonal influenza vaccine and the Tdap vaccine in the third trimester. And, within the last couple of years, that expanded to also including now there are 3 vaccines that we discussed in pregnancy, including the COVID vaccination. And then now, just in the last month, now saying there are 4 vaccines that we discussed in pregnancy, and that now includes the RSV vaccine, a Bracewell vaccination for respiratory syncytial virus. So I included them in a kind of a list here as far as how they've added into my conversation with patients. But how I've included them in the presentation is kind of in kind of my seasonal approach, or kind of how we're dealing with them right now. And so influenza vaccine is the first vaccine that I wanted to talk about today. And I feel like one of the most common things that I'm saying when I'm talking to patients is we're talking about influenza, and influenza is not necessarily what everybody talks about as flu. And so talking about what is influenza. Influenza is a viral infection. Typically, we're talking about respiratory system. And so, influenza can be a range of symptoms. For some, it feels like a common cold, but usually it hits a little bit harder, a little bit faster. And it can progress to something much more significant than a common cold. Oftentimes people are going to experience fevers. They're also going to experience muscle aches, body aches. So influenza itself can be really awful, but we also know that influenza can cause significant complications. And so those who are at higher risk for complication from illness in general, those who have pre-existing health conditions like respiratory illness, like diabetes, like cardiac disease, are at more risk. But we generally just see that influenza can flare up asthma. It can lead to secondary bacterial infections like pneumonia. We can see acute respiratory distress syndrome, ICU admission, and we can also see heart problems. We can see heart attacks, myocardial infarction. We can see myocarditis or inflammation of the heart. We can see heart failure associated with influenza. And so why do we care specifically in pregnancy? And it's because influenza poses risk not only to mom, but to baby as well. And so influenza, when we look at the risks to mom of influenza in pregnancy, we know that mom's immune system has changed due to the pregnancy. We know that mom's cardiac system has changed, and we know that mom's respiratory system has changed as well. And so when mom has influenza during a pregnancy, we know that there's an increased rate of mom to be really sick. We see that there's a high rate of hospitalization, and sometimes that just means that mom needs a little bit of respiratory support. We need some IV fluid resuscitation, but we also know that there's a higher risk for mom to have to go to ICU. We know that there may be a risk for mom to need intubation. So more than just a little oxygen by nose, but mom may need full support that she can't breathe on her own. Not only does mom have high risk herself, but we also have significant data that shows that when mom is infected with influenza during pregnancy, we see adverse pregnancy outcomes. So we can see both increased risk of preterm labor, which may or may not be able to be stopped, and preterm birth. So in those scenarios where we're not able to stop labor, that we may progress to actually delivering baby too early. Even if babies are born at appropriate gestational age, we can see that those babies may not gain an appropriate amount of weight throughout that pregnancy. There is an association of influenza and miscarriage and pregnancy loss. And we also see, especially with influenza infection in first trimester, especially associated with the maternal fever, there is a risk for neural tube defects. So development of the fetal brain and spinal cord. So we definitely know that there are negative impacts of influenza infection during the pregnancy. So influenza vaccination, this is something that changes yearly based on a whole lot of data that a lot of people that are a lot smarter than me are able to gather and predict and put together. So this is a table that is available from the CDC of all of the vaccinations that are available, approved on the market in the United States for the 2023-2024 seasonal influenza vaccine. And so when we break these vaccines down, we talk about like, okay, all of these are out here. What do we actually give? And so the ACIP, which is the Advisory Committee for Immunization Practice, says that we can give any influenza vaccine in any trimester that is appropriate as far as the age of the patient, that is either a recombinant or inactivated vaccine. So this means any flu vaccine that is not a live vaccine can be given during pregnancy. The live vaccine can be administered postpartum, but we never give live vaccination during pregnancy. This year, sometimes flu vaccines are either trivalent or quadrivalent. In 2023-2024, they are all quadrivalent. So I have a list here of the vaccines that are available and recommended. So the only one that has a specific age range that is for adults only. So if you are a pregnant patient who is less than 18, we're looking at that inactivated series. Those are all for greater than 6 months. If you are 18 or older, then flu block would be one that you would be eligible for as well. A lot of this is going to depend on what clinic, what pharmacy, what public health office that you're at, and what vaccines they have available to them. At this point, there is no recommendation for one brand over another as far as which ones do we give. And there's no recommendation for inactivated over recombinant as long as somebody is over 18. One thing that commonly gets brought up and is something that kind of, I think, ebbs and flows as far as concern is mercury in vaccines. Mercury has had a bad rap in vaccination for different things over the years. So the preservative that can be used in vaccinations is called thimerosal. And thimerosal is an important ingredient in some vaccination because it provides protection against things that could be growing in these vaccines that we absolutely don't want to, things like fungus or bacteria. And so in vaccines that are provided in a multi-dose vial, we want to make sure that other things aren't going to grow there. And so only certain vaccines are going to contain thimerosal, which you can actually see in the final column here in the CDC table. Thimerosal has a type of mercury called ethyl mercury. So this is actually different than methyl mercury, which is the one that we kind of think of more when we talk about like deep sea fish, or when we're counseling pregnant patients about limiting mercury intake through pregnancy. Thimerosal, the ethyl mercury, is metabolized very quickly. It does not build up in our body. We don't get an additive dose over time. And this is something that is used in many medical products, and it has a very long safety record. So something that you can be really confident in explaining to patients, or if you are yourself a patient, you can feel really confident that this is a safe thing to receive. It does not cause autism. It does not add up in your body. It does not cause poisoning. It's a safe ingredient. So when we look at vaccination, influenza vaccination in pregnancy, we know that we're benefiting mom by decreasing her risk for severe illness. We know that we're reducing her risk for hospitalization, secondary bacterial pneumonia. And we also know that one of the really cool things is that when mom receives this vaccine throughout the pregnancy, her body is able to pass on that immunity to baby through that placenta. So not only does mom have that protection, or protecting the pregnancy from complication, but baby is also getting that benefit of the immunity. Risks of vaccination in pregnancy in regard to the influenza vaccine. Like any vaccine, influenza vaccine is going to have common side effects. So local injection site reaction, soreness, redness, swelling. Some people will get a little muscle ache. They'll feel just a little bit junky for maybe a few hours, 24 hours after that vaccine is administered. There's a rare risk with all vaccines that there could be an allergic reaction. One thing that's very, very reassuring is that the influenza vaccine does not increase our risk of miscarriage or stillbirth. And this has been shown over many years and a lot of data. And we know that this is safe to give in all trimesters. So two different studies can be referenced at this point. So there was a study published in 2019. It was using the CDC's vaccine safety data link. So this is taking all of that research, all of the information that we collect about giving vaccinations and reported side effects and reported complications. And so this is one of the largest studies that's been done, and it evaluated 3 different flu seasons. So starting in 2012 to 2015, they looked at over 1,200 cases of miscarriage, and they were able to definitively say there were 0 that were related to influenza vaccination. Another study that was published in 2020 using the same data was able to look at 795 cases of stillbirth. Again, they were able to show 0 connection between influenza vaccination and stillbirth. So we have good data. We know that the CDC is collecting this data, and we know that it continues to collect this data, and that people are continuing to use data. Even from a decade ago, they're continuing to collect this, and they're continuing to conduct studies to confirm that we really do know that this is safe, and we really do know that it is effective. So that's what I have to say about influenza. 2 of my favorite resources when it comes to influenza vaccination and talking with patients are ACOG, the American Congress of OBGYNs, and SMFM, so the Society for Maternal Fetal Medicine, kind of our high-risk obstetrics experts. And so they have a lot of really great data that's very patient-friendly, that's not complicated wording, that talks about the importance of influenza vaccination in pregnancy. So here's just a couple infographics from those organizations about flu vaccine and pregnancy. So transitioning to our next topic, so another thing that is coming that we now are anticipating upticks in COVID-19. It's still here, it's real. I still have patients that are questioning the validity, but it is real, and I do recommend vaccination. So what is COVID-19? We know it's a viral illness. We know it's caused by the SARS-CoV-2 virus. We know it's incredibly contagious. We know it's an incredibly long list of symptoms. And we know it's kind of unique in that it can be anywhere from completely asymptomatic and you had to take a test for work or because somebody else in your life tested positive, to very, very ill. And so I think, most of us at this point have heard enough to know what the common symptoms are. Many people have fevers, chills, sore throat. A lot of people kind of have that alert when they lose their taste or their sense of smell. People are oftentimes experiencing pretty severe headaches and fatigue. And so those are some of our common symptoms, and they can be varying in their severity. One of the things that we really worry about is that COVID can absolutely lead to severe illness. And in a lot of cases, it doesn't really seem to matter. COVID doesn't really seem to care whether you are elderly, whether you are young, whether you have pre-existing conditions or not. Of course, we see that those who have cardiac disease, those who have lung disease, those who are obese, those who are generally more ill, immunocompromised, tend to be hit harder, but there are always cases where people are genuinely fairly healthy and still get very, very ill from COVID. And so some of the things that we see specifically from COVID is that respiratory failure. So we go from coughing, shortness of breath, to needing respiratory support. We need a ventilator. We need a breathing tube to help us breathe. We know that we can go from having, a relatively mild infection to having a systemic infection affecting our entire body, an infection that's now affected our bloodstream related to COVID. We know that COVID increases our risk of blood clots. We know that it can affect all of our organ systems. And if you have followed any trends since early 2021, you know that we have seen an absurd number of deaths related to COVID. One of the other things that we are talking more and more about is long COVID. What happens when we have this viral infection and we have persistent symptoms for months and sometimes years after we clear that initial virus? So again, when we look at pregnancy, why are we specifically talking about COVID and pregnancy? And again, it's because we know that COVID can affect both mom and baby. So when we look at those specific risks of COVID for the maternal side of things, again, similar to influenza, we see a higher risk for severe illness. And this is despite the fact that typically when we're looking at patient populations, if you're young enough to be pregnant, you're typically in the younger side of things. And so despite being relatively young, we still see a high rate of hospitalization. We see high rate of ICU admission, and again, need for mechanical ventilation, need for intubation. One of the things that's specific to pregnancy related to COVID-19 is an increased risk for both preeclampsia and eclampsia, which are hypertensive disorders of pregnancy, so high blood pressure, as well as kidney and liver dysfunction. So these things are complications of pregnancy with or without COVID-19, a major cause of morbidity in pregnancy. And so COVID-19 infection really increases the risk of those occurring. Pregnancy itself increases our risk for developing blood clots. COVID-19 infection also increases that risk. So we definitely see an increased risk of blood clots. We also are seeing that it's a higher likelihood, aside from other pregnancy complications, to result in a cesarean birth. We also see just generally higher rates of pregnancy complications, postpartum hemorrhage, cesarean deliveries, and so gestational diabetes, preterm deliveries. So generally, we're seeing more complicated pregnancies in those who have been impacted by COVID-19 infection. Additionally, when we look at fetal impact of COVID-19 infection, we're looking at that increased risk of preterm birth for baby. And so we see this especially true when there's maternal infection in third trimester. We also definitely see an increased risk of stillbirth. And we see higher rate of NICU admission, and in some studies also showing longer NICU stays for babies who are impacted by maternal COVID infection. So when we look at vaccination for COVID-19, currently there are 3 approved COVID vaccines: the Pfizer COVID vaccine, the Moderna COVID vaccine, and Novavax. So currently, these are all available. They've all been updated for the 2023-2024 season. And I have listed here the updated recommendations. These were as of last week per the CDC guidelines. I know these are changing a lot, but I am anticipating when I checked this morning, they were still the same. So this is the current guidance as far as if you have had previous vaccinations or if at this point you have not received any vaccinations, but you are open to vaccination. When it comes to what vaccination we give in pregnancy, currently there's no recommendation for preferential treatment of one vaccination over another. All of them are equally effective. All of them are equally recommended. One thing that I think is really important is that there's been a lot of fear about these vaccines. You know, we are living in an age where we've had great opportunity in that earlier generations have really taken the brunt of many of the other infectious diseases. Vaccinations like chickenpox, like measles, mumps, rubella, like polio, those have been around for a long time. And so we have not seen the impact of those diseases. And so understandably, there's some fear for a lot of people about something that's new. And so some reassurances that I like to be able to give is that these vaccinations are incredibly safe. These vaccinations do not contain anything that is harmful. There's no fetal animal tissue, no metals. These vaccines do not interfere with our DNA. These are incredibly safe vaccines. These are probably the most highly studied vaccines. There's the most rigorous safety data collection throughout the trials and ongoing. And so one of the other things is that one of the common concerns that I hear from patients is, how do we know the long-term impact? And I can feel really confident in saying we know because the vaccines don't stay in our bodies. The vaccines are in our bodies long enough to trigger that immune response and do what they're intended to do. And then our body gets rid of that vaccine and its components, just like it gets rid of everything else that enters our body. And so we know that there's not long-term risk because the vaccine doesn't stay within our system. And so that's something that you can feel really confident in too. Benefits of COVID vaccination in pregnancy, we know without a doubt that it decreases the risk of severe illness. We know that it's less likely that mom's going to be admitted to the hospital, to the ICU, need mechanical ventilation. We also know that it decreases that risk of hypertensive disorders, preeclampsia, eclampsia. We can decrease that risk of preterm birth and then the down effects of a baby that's born too early. Again, just like influenza vaccine, we know that there's passive immunization. We know that when mom receives that vaccination during pregnancy, her body creates those antibodies. Those new antibodies are able to pass through placenta, and that newborn has protection at birth. When we look at risks of COVID vaccination in pregnancy, again, just like every other vaccine, we have the potential for injection site reaction. When we look at the vaccine adverse events reporting system, we have noted 4 serious adverse event types in the grand scheme of the vaccines that are currently on the market. Just like the risk with every vaccine, there is, of course, a rare risk of anaphylaxis, allergic reaction. There have been some reports of myocarditis, pericarditis. Again, like many vaccines, there is a risk of Guillain-Barré syndrome. There have been some rare reported risks of thrombosis with thrombocytopenia syndrome. And so overall, when we look at the occurrence rate of these serious adverse events, and we look at the risk and the occurrence rate of infection, all of our major organizations still say that vaccination far outweighs the risks of those potential vaccination risks. Again, when it comes to pregnancy specifically, we know that there are no specific maternal or fetal risks. So we know that there is no increased risk of miscarriage, stillbirth, birth defects, preterm birth related to vaccine itself. We have published data. There's a systematic review meta-analysis that looked at over 23 studies, looking at more than 110,000 vaccinated patients, that was able to definitively show that we did not see these increased risks. One of the things that I think is really cool on the CDC website for COVID vaccine and pregnancy, there's a resource that's called Mother to Baby. It has a phone number, it has a chat function, it has an email. It's available in both English and Spanish. So if patients have concerns about COVID infection, they'd like to be able to talk to somebody about vaccination, about pregnancy. There is an expert who is able to have that conversation with a patient. I wish I would have remembered to put that link in the presentation, but it is on the CDC website, and it's a really, really cool resource. So that is available. Again, just like my infographics for influenza vaccine, I appreciate ACOG and Society for Maternal Fetal Medicine. They have some really great information, really quick, really patient-friendly information about these vaccines in pregnancy. Let's see here. RSV, this is a new guy. Very, very exciting. So RSV. So I will say this vaccine is super exciting. This has been essentially my career in the making. I remember being a student and hearing about this and kind of this theory of like maybe someday we're going to be able to do this like we do Tdap. And we'll be able to give this vaccine in pregnancy and protect babies. And so it sounds a little bit corny, but I actually remember the exam room that I was in, and I got the news alert that this was approved on September 28th for use in pregnancy. So this was super, super exciting to me. And I'm really grateful to have the opportunity to talk about it, especially because there's not a lot of us talking about it yet. So RSV, respiratory virus, it's a cold-like illness. You'll probably sense a theme here. The season is really now. It starts in the fall, it kind of progresses through winter, it kind of lasts into the spring. Just like some of the other things, it can be fairly mild, can go away on its own, but it also can be really, really severe. We can see it create high fevers, it can create breathing problems. And again, our biggest concern is progression to things like pneumonia or bronchiolitis. So when we actually look at the infant population, it is the #1 cause of hospitalization in the US. And so infants, sometimes they just need to be admitted because they need a little blow by oxygen. They need a little bit of fluids to keep that fluid volume in because they can't take in oral fluids very well. But some of them may actually need to be intubated. They may need mechanical ventilation. And so again, like why do we care in pregnancy? And really the reason is up until now, we had really limited pharmaceutical intervention that we've been able to give. Synagis, I'm sorry, I don't know how to pronounce the generic names. And this was kind of our go-to option, but it had a pretty limited indication. It was for those who were premature, who had a chronic disease. And it was given during RSV season. And so the really amazing thing is we now have the opportunity to protect before babies are exposed. And so, again, just some information about the impact of RSV. And so RSV can affect, infants through the elderly. And oftentimes in those who are, teenagers and adults, it kind of creates just kind of a cruddy viral illness. But for those who are on those extremes of the age range, it really can cause significant illness. And so just this year, we've had a really pretty significant change in what is available for RSV. So the one that I'm specifically wanting to talk about today is the Abrysvo, which is the one that is approved, indicated for use during pregnancy. Those that are recommended for young children are the monoclonal antibody treatments. So Synagis, which has been around, and the new one that's available, which is the Beyfortus. Interestingly, for adults, we also have 2 vaccines available. The Abrysvo also has an indication for older adults, and there's another one that's called Arexvy that's out there as well. So when we look at the maternal RSV vaccine, we see that it's recommended for pregnant people to protect their newborns from severe illness. It's a one-dose vaccine. It's recommended at 32 to 36 weeks gestation. We give it between September to January. Benefits of vaccination, benefits of RSV vaccine in pregnancy. Again, really the goal here is that passive immunization. And so we know that when we give this vaccine to mom, we know that her body will create those protective antibodies. Those antibodies pass through placenta, and baby is born with those protective antibodies. And so we know that it shows a significant decreased risk for severe illness. Risks of vaccination, again, just like every other vaccine, we have common injection site reaction. There's a rare risk of serious allergic reaction. This is a newer vaccine. There were a couple things that they noted. There's ongoing studies, of course, because they're still collecting data. So they did want to note that there were two pregnancy complications that were kind of flagged and noted, and they're looking at more strongly. They did see a slight increased rate of preeclampsia in the vaccinated group. They also saw a slight increased rate of preterm birth in the vaccinated group. However, major caveat in these is that when we look at it, these were not statistically significant differences. And so, there's always going to be a background rate of risk for these things in any pregnancy. And so, there has to be really good transparency, really good clarity about what we're seeing in these trials and what data we're putting out. So this is a good conversation to have. It's important to note this information. But this, especially given that there was not statistical significance in this difference, we still feel like the benefit of RSV vaccine outweighs these potential risks. So one of the questions that I think is a fair question is, why do we give it in pregnancy if we can just wait and give it to the baby? And one of the things that I think actually the Society for Maternal Fetal Medicine addressed really beautifully was essentially, we know that the efficacy, the benefit of maternal vaccination is very good. We know that it's very accessible, and we know that benefit is there right away. One of the concerns was that we may not have good access to that monoclonal antibody, that cost is higher, and that we may not be able to provide that to infants in this RSV season, or as quickly as we'd like to get that protection in place before RSV is raging. And so, so I think kind of what we are seeing and what the CDC recently put out an official advisory on is that that's absolutely true. Currently, we do not have enough of the monoclonal antibody to provide for all of the infants that will be entering their first RSV season. And so if we were to rely on that alone, we would be leaving a lot of infants unprotected in this current season. Again, when we look at cost, when we look at private sector quote, at least through the CDC, the monoclonal antibody is more expensive than the maternal vaccine. Again, when we look at the timing of benefit, baby has benefit right away when mom's given that vaccine during the pregnancy, instead of waiting to get that until birth. One of the other things that I think is, a kind of a side benefit, although that it's not the indication, mom does still have some benefit of those antibodies. She's unlikely to have significant illness from RSV, but she still has some protection. And one of the things that I think of is, if I can stick a grown-up instead of a newborn, that's something I probably have some interest in. So something that I would think about. And one of the reasons I think really this one hit me really hard is just in this last year, I had numerous patients who came for that postpartum visit 6 weeks after delivery. And they came for that visit directly from the hospital. Because their newborn was currently admitted for RSV. So had left their baby bedside with a partner or a grandparent to come and have their checkup, and then plan to head back to the hospital. So we had a pretty wicked RSV season last year. And so having an opportunity to really make a difference here, I think is pretty amazing. The last one, Tdap, common comment is like, no, I'm pretty sure. Yeah, I think I had that. And yes, you probably did, but our indication is a little bit different in pregnancy. And so just in the interest of time here, I think I'll probably speed things a little bit through and won't go probably into quite as much detail. So really what we're targeting here with this Tdap vaccine is pertussis or whooping cough. And so this is actually a bacterial infection. So this is the first one we've talked to today. That is not a viral infection, it's a bacterial infection. And probably the most that people know about it is that notorious whooping cough that it can cause. So it absolutely causes a respiratory illness. It can cause this cough that is characteristic and can really last and persist long after that initial infection has resolved. One of the things we really concern ourselves with is that, again, like some of these other infections, not only can this initial infection be a problem, but it also risks secondary infections like a bacterial pneumonia. One of the other things we see, especially in infants, is that there's a higher risk for seizure, encephalopathy, brain infection, and complications. And we know that these things, as complications from infection, can really, really affect development. And so that is why we really, really want to do our due diligence in protecting infants against pertussis or whooping cough. So again, when we look at why do we care in pregnancy, infants under age 1, they're the highest risk for pertussis as far as infection and the most severe complications. Currently, when we look at the vaccines that are approved for infants, the DTaP vaccine that is given as part of routine pediatric immunizations is not administered until at least 6 weeks old. And so from birth up until we've really completed the first part of that immunization series is when those infants are at the highest risk. And so technically Tdap protects against 3 different illnesses. Pertussis, again, not probably as significant as some of our other infections, but we are seeing increasing rates in the United States. And usually those who are affected are those that are too young to be fully protected by their own vaccine series yet. So Tdap vaccine, currently there are 2 on the market, Boostrix and Adacil. This became a recommendation to routinely give this in 3rd trimester of pregnancy in 2012. We now have more than a decade of safety data on this vaccine in pregnancy. And we know that it is significant in its benefit. So again, 90% we're able to avoid hospitalization, and it prevents more than 75% of cases. And so again, it's this concept of protecting baby before they can protect themselves. So benefits of vaccination, we have that decreased rate of both newborn and infant pertussis infection. We have a decreased rate of severe illness. So when babies do get infected, they have a much less likelihood of severe illness and those severe complications. A side benefit, we're keeping pregnant patients up to date on their own immunizations. And one thing that I always like to talk with patients about is this is a good reminder for the other adults that will be in this newborn's life to make sure that they are up to date on their own immunizations. So kind of a conversation that I often have is, this is my plug for public health is, we recommend your Tdap vaccine in the 3rd trimester of every pregnancy. This is a good reminder to dad, to grandma, grandpa, aunts, and uncles, everybody who's going to be around this baby, to make sure that they're up to date for their Tdap vaccines. And I also recommend making sure they're up to date for their own influenza and COVID vaccinations as well. So if I can spread that out, I really like to be able to do that. Risks of vaccination in pregnancy with that Tdap vaccine, really, really similar. That injection site reaction, again, very rare risk of a serious allergic reaction. Of those 10 years of good safety data, we have no increased risk for pregnancy complications. We have no safety concerns when we've followed these babies through this decade of data. When we've seen the babies who have been affected by maternal vaccination. So we know that safety data is really good. Here's a really good patient education infographic from CDC on Tdap in pregnancy. So again, one of my really, really strong points is who can I trust for vaccine information? So my #1 go-to is ACOG, Society for Maternal Fetal Medicine. The really nice thing is that they are always in line with the World Health Organization and CDC and the National Institutes of Health. So these are all good resources, whether you're a clinician, a patient, whoever you are trying to seek this information. This is a really nice, just kind of infographic explaining kind of how this maternal immunization works. How does it work? When we give mom a vaccine, how does this work for the baby to have that benefit? So I just like to include that because I think it's cool. Just a little plug as I was going through all of this. There's another similar lecture tomorrow by people who are more highly educated than I am. And so if you're interested in a deeper dive, more information, more input, I thought this was really cool that there's another really, really similar talk that you can access. Again, a good resource and a free resource. So that you can check that out and hear are all of the resources that I accessed. So I really appreciate your time today.
Awesome. Thank you both for such wonderful.
Mary, looks like you froze if you can hear us. Now you're back.
Can you hear me now?
Yes. Yep.
Okay. I will try sharing again. I just thought maybe unsharing and sharing would. Let's see here. Am I froze still?
No, you're good.
No? Okay. Good deal. All right. So there is an evaluation survey that you can scan as we kind of look to see what questions have come in. I am just going to quick look here. I don't see anything in the Q&A, but feel free to drop any question there and we can address it. One did come in during registration, and it is how effective are lifestyle measures, including masking, gloving, and hand washing, at preventing respiratory illness among pregnant people? Either of you can chime in.
So I'll just start out. Mary did send me this question this morning, and so I did try to take a little bit of time to see if there was anything in the peer review literature about those factors, just specifically among pregnant women and their effectiveness. And I didn't to date have not, or to date, the few hours I had today, I didn't really find anything that specifically talked about those interventions for pregnant people. And so I don't know if Melissa, you have any other information. My inclination would be, things like washing your hands are going to be effective for absolutely everybody. And so following that, a good lather and singing happy birthday 2 times is going to be the good way to go.
Yeah, I kind of did the same, and unfortunately did not come across anything that was pregnancy specific, which actually doesn't surprise me. That's kind of a trend. It's hard to collect a lot of data specific to pregnancy. I think that we have seen a lot in the era of COVID coming out and showing us that there is good data to support the benefit of hand washing, of masking, of social distancing. You can find that data through World Health Organization. You can find that through the CDC, through the NIH. And so just like I would recommend that to all patients, yes, of course, it's going to be helpful for pregnant patients as well. But just like I would counsel other patients who are at increased risk, that is not a substitution for vaccination, because we know at the end of the day, the vaccination is going to get us the best success for protection.
Awesome. Thank you for that. And I don't see any other questions that have come in. So I will just move along to our last slide. Thank you guys so much for presenting. This was such a good presentation. And thanks everyone who could attend this presentation. To stay connected with us, you can follow Healthy NODAC on Facebook, Instagram, Twitter, and Foundation for a Healthy North Dakota on LinkedIn. Also, to join the coalition, visit the link to stay aware on future webinars and updates on the foundation. And lastly, here is the QR code. You can take the evaluation. We'd love to hear from you. So Thank you, everyone, and have a great rest of your day.
Awesome. Thank you so
Thank you
much.
so much. Take care, everyone.
Thanks.